Thank you, Fiona, and thanks to Fiona and all the team at UPMC Sports Surgery Clinic for organising the event this evening. As Fiona said, I'm a shoulder surgeon, so I'm certainly not an expert on the menopause, but there is a particular shoulder condition that we tend to see more commonly in women and often around the time of the menopause, and that's frozen shoulder. So we thought we would include that this evening. The other name for it being adhesive capsulitis, and I'll explain that a little bit. So, in terms of shoulder pain around the time of the menopause, there is good evidence to show that the most common diagnosis, both premenopause and perimenopausal, by far is adhesive capsulitis or frozen shoulder. So almost a third in both cases, whether it's right before the menopause or around the time during the menopause, the diagnosis behind a shoulder pain is frozen shoulder. The second most common diagnosis was shoulder synovitis, which often goes hand in hand with frozen shoulders, inflammation of the lining of the joint. More common, that was found in the actual perimenopausal group rather than premenopausal. But the point is that shoulder pain around the time of the menopause is far more commonly due to frozen shoulder than in the general population, where there's a lifetime prevalence of frozen shoulder of about 2 to 5%. Yet in the perimenopausal and premenopausal population, you're looking at 35%, 32% of all shoulder pain is due to frozen shoulder. So what is it? We'll discuss that. Who tends to get it? What is not frozen shoulder? How do we go about figuring it out and diagnosing it? And then how do we treat frozen shoulder once we have arrived at that diagnosis? These are the things that I'll go through this evening. So the terminology that's often used medically is adhesive capsulitis. The capsule of the shoulder joint is the lining around the ball and socket. So the shoulder joint is a ball and socket, capsule around the joint, and the capsule gets inflamed, and that's the capsulitis. The adhesive part is, I suppose, reflective of the fact that there tends to be almost like adhesions or fibrous tissue where the capsule gets really tight and thick and scarred. And so that's how it's come to be known as adhesive capsulitis. We don't really know why this happens. There are some theories out there, but there's often no real cause for it. It's important when somebody has a painful and stiff shoulder that we don't just call all of those things frozen shoulder. There are other things that can present like that, and those need to be ruled out before we make a diagnosis of frozen shoulder. So one of the other things that can present with a painful stiff shoulder is arthritis of the shoulder joint. The very simple way to make that diagnosis is with an X-ray. And you'll see, as on the X-ray here in the picture, where instead of there being a nice ball and socket and some space between the ball and socket, that space on the X-ray is no longer really visible. The space reflects the cartilage. The cartilage is worn away. And there's, in that picture, what you would call bone-on-bone arthritis. Whereas in frozen shoulder, the capsule is inflamed. X-ray should look pretty normal. There are other situations where it's difficult to move the shoulder. For example, with severe weakness, it can be very difficult to raise the arm. And that can happen with a massive tear of the rotator cuff. And sometimes people will make the mistake of calling that frozen shoulder because it seems as though the patient can't move the shoulder at all. But in fact, if you take your other hand and move the arm up, or if I move the person's arm, there is movement there, they just don't have the strength. And so we're differentiating the passive from the active movement. In frozen shoulder, both will be really stiff, whereas in a case of severe weakness, the passive range of motion will often still be there. Sometimes the shoulder is just simply too painful to move. But if we again move it passively, it's possible to move through the pain, whereas with frozen shoulder, it's not actually possible to move beyond a certain limited range, or what we call a capsular end feel. The physiotherapists will often refer to that. And so basically with frozen shoulder, the shoulder must be stiff actively and passively, but have a normal X-ray. People find it quite frustrating when we can't explain why they got a frozen shoulder, what caused it, did they do anything? Usually no. And there's no real consensus on what causes it. It is inflammation of the capsule. So usually it's idiopathic for no good reason. It can happen after trauma. So sometimes you'll see somebody who falls or has some trauma to the shoulder, doesn't actually do any structural injury to the shoulder, but the shoulder responds by getting really inflamed. And that can result in a frozen shoulder. One theory is that if there's a minor injury to the shoulder, then the first response is inflammation, which is normal. The first stage of any healing is inflammation. And if the shoulder somehow gets stuck in that inflammatory phase or overdoes the inflammation, that can actually result in frozen shoulder. There are some theories about it maybe being autoimmune. And then sometimes we see it if somebody has sort of had less movement of their arm for an unrelated reason. For example, if they've been put in a sling for something else. So that's often why we don't put, say, hand and wrist injuries or elbow injuries into a sling very much, because the shoulder ends up getting stiff. Sometimes we see it after something like a pacemaker insertion, so on the left side, and maybe there's a bit of soreness there for a little while afterwards. The person doesn't move their shoulder as much and they can develop a frozen shoulder, or after breast surgery or irradiation to that area. But there's no definitive cause known for frozen shoulder. It was interesting during COVID, we saw that there was an increase in the presentations of frozen shoulder to us at the clinic, and we wondered, were we imagining it, or was there actually a pattern to it? So we analyzed that time period compared to an equal time period beforehand, and we found, yes, there were a lot more frozen shoulders. It increased by more than a third in terms of presentations. It wasn't any different in terms of the severity or how it responded to treatment, or what proportion needed surgery. And other centers have found similar phenomenon as well. We don't have an explanation, but the theories were that perhaps it's related to a low-grade pro-inflammatory state. So either if people had subclinical or even clinical COVID, was that somehow related to frozen shoulder? Or perhaps stress. Everybody was under some mental distress at the time during the pandemic for various reasons, and that is a pro-inflammatory state, and whether that somehow translated into an increased risk of frozen shoulder is unclear, but we were able to see that there was a spike of frozen shoulder during COVID for whatever reason. So there are associations, classic associations with frozen shoulder. Diabetic is probably the most well-known one. Thyroid disorder is usually underactive, but it can be overactive thyroid as well. And the one that we're discussing tonight, around the time of the menopause. So those are all hormonal disorders. So there does seem to be some interplay between the endocrine or hormone system and frozen shoulder. It's yet to be explained fully. But the associations are not causes. They're sort of seen as patterns. Typically, frozen shoulder affects females in their 40s and 50s, but we do see men with it, and we do see people outside of those age groups. The way we go about making a diagnosis, the history can often give us a clue. So many people with frozen shoulder will have those typical associated factors that we've just mentioned, not always. And then the classic pattern is that there's been this gradual onset of pain, which is worsening over time, and it can be very, very severe pain, particularly with any sudden movements, which is a sign of capsular irritation, or having to reach or overstretch beyond the range that's available as the shoulder starts to get a bit stiff and irritable. A lot of people find things like getting dressed or undressed or reaching out to take a ticket out of the machine in a car park can be really painful. Usually the pain starts first and then the stiffness comes in a little bit later. The capsule is becoming thickened and tight as it becomes more inflamed, and that's making it physically impossible to move the shoulder, and that's why it's limited both passively and actively. In fact, if we were to put someone asleep who has frozen shoulder, so we give them a general anesthetic, muscles are completely relaxed, they're not feeling any pain, they're fully asleep, fully anesthetized, the range of motion is still the same, because it's a physical block that this thickened, tight capsule is creating, physical block to movement. Typically, frozen shoulder will get better on its own if nothing is done. But the reason to think about doing anything about it is that can take quite a long time. So it can take up to 2 to 3 years in some people. And it tends to go through these phases where it's painful and intensely painful. Then it becomes stiff and painful. The pain gradually fades away and you're just left with stiffness. And then eventually the range of motion comes back and the shoulder does tend to go back to normal. There's nothing wrong with the shoulder joint, the underlying joint itself. It's this inflammatory process involving the joint capsule that does burn itself out eventually. But because it's so miserable when people have it, it's not entirely reasonable to just wait 2 or 3 years to get better. The other ways we diagnose it then are by doing a clinical examination. And unfortunately, for whatever reason, this part is often skipped and everybody with shoulder pain is just sent for an MRI, and that's where things can get confusing. What we're looking at in the clinical exam is the shoulder being irritable with range of motion, and that obviously is non-specific. A lot of other shoulder problems can show that as well. But often we find pain towards the end range of motion. And then if it's very early in frozen shoulder, that might be the only thing that we find. If it's a little bit later, then stiffness will have developed, and the stiffness should be of both the active and the passive range of motion. All we usually need is an X-ray, and many people will already come having had an MRI. But if we examine the shoulder and there's no weakness, we can establish that the rotator cuff muscles and tendons are all working well, and we have a stiff, painful shoulder. We take an X-ray just to make sure it's not arthritic. And if the X-ray shows a normal joint, then we know it's the capsule, and that's our diagnosis. Um, so it's a combination of history in a typical patient, the clinical exam, and an X-ray being normal. The thing about the MRIs, and we've I suppose learned this and gotten that message out there that not every back pain gets an MRI, but for some reason in Ireland, every shoulder pain still seems to get an MRI. And the reality is that nobody of the age around the time of menopause, in fact, nobody over about 30 is going to have a normal shoulder MRI. There are normal age-related changes that start to happen within the tendons, little bits of wear. They're not necessarily significant, but the radiologist has to describe everything they see. So when you get an MRI of your shoulder, you'll have a big, long report. And what we often see is that things get inappropriately emphasized in that report and people get sent down the wrong road. When the reality is that often if you MRI'd the asymptomatic shoulder, it would generate a report very, very similar. So we don't encourage getting MRIs without a good clinical exam, and often we don't need it in cases of frozen shoulder where we have a good exam. We don't need the MRI to make the diagnosis. It can be pretty uncomfortable to lie inside a scanner for 20 to 30 minutes if you have capsulitis of the shoulder. A lot of patients with frozen shoulder find that their pain is quite bad at nighttime, and it's quite uncomfortable when they lie down. Same thing inside a scanner. So the times when we will ask for an MRI is if we can't establish on clinical exam that the strength of the rotator cuff is normal, because sometimes the shoulder is so sore when you have a frozen shoulder that it's really hard to actually cooperate with the exam and do all the tests and sort of push and pull against the examiner's hand because it's just too painful. So a lot of times we'll check an MRI for that reason, but the vast majority of people we can get an exam and understand what's going on without necessarily having to put them through having a scan. Sometimes you can have a rotator cuff tear that gets secondarily stiff, and that's sort of a secondary frozen shoulder, which is a bit of a different scenario. So then if you have a frozen shoulder, what to do with it, how to treat it. So the first thing is pain management. If you're still in that painful phase, we need to decrease the pain to give back quality of life, to get back sleep, and to allow you to then do some gentle stretching of the shoulder. Because it's an inflammatory problem, we use anti-inflammatories as first line. Usually you start with the non-steroidal anti-inflammatories, simple things like ibuprofen, or maybe some of the prescription non-steroidal anti-inflammatories. It's also reasonable to do a short course of oral steroids. Yes, that's giving steroid to the whole system, but in a very short burst for maybe a week or 10 days of a decreasing dose. And many times GPs will be happy to give that, and that can give a really intense burst of anti-inflammatory treatment, which helps the frozen shoulder. Other simple things like using heat to kind of loosen it out, using ice to settle it down before you go to bed at night. Those are kind of the basic pain management strategies. We also then suggest very gentle stretching, maximum 5 out of 10 discomfort when stretching. Getting into a pool can be really helpful. People often say, well, I like to swim in the sea. Can I do it in the sea? It's not quite the same. I think you need the warm temperature of the water to help you stretch. Often people with frozen shoulder have been sent to physiotherapy and they have found that it has aggravated it, and they actually feel that physio made them worse. And I think that probably is because the instinct on the part of the physiotherapist is to try and push and get range of motion back and not let the shoulder get stiff. But when there's frozen shoulder, when there's a capsulitis, that often just actually makes it worse, and it tends to get more painful and then more inflamed and then stiffer. So usually we have people just stretch by themselves and do some self-directed stretching rather than having anybody else go at the shoulder, particularly when it's in that irritated phase. Sometimes if a shoulder is really sore, you might feel like you want to give it a rest and put it in a sling, but that's probably the worst thing to do because it will just get more and more stiff with that. So no slings for frozen shoulder. Try to gently keep it moving. With the pain management, sometimes we'll add an injection of steroids. So usually if somebody has come to me, they've probably tried some of the simple things already and will be thinking about injecting cortisone. The diagnosis needs to obviously be made first. We need to make sure the injection's going to the right place that it needs to be. And I wouldn't advise having any more than 3 steroid injections, because if you keep having indefinite amounts of steroid, it can have a negative effect on other structures in the shoulder, such as the tendons. The vast majority of cases of frozen shoulder, absolute vast majority, will resolve with anti-inflammatory treatment, injections, and gentle stretching. Most don't end up needing further treatment. We use just very, very simple stretches for frozen shoulder, which anybody can find on our website under services, and then stiff shoulder stretches. And you'll see some videos here of how to do the stretches for different directions of movement. And with frozen shoulder, again, we do advise not pushing the stretches really hard so as not to aggravate that inflamed capsule. Getting in the pool and doing some very simple things can be helpful as well, just walking in the water and some stretches, in addition to those dry land stretches. And that's what we prescribe our patients. In terms of cortisone injections, a lot of times people will come to us and may have had an injection already, but found that it didn't help a lot. And I think a lot of the time that's probably because it was in a different space than where the frozen shoulder is. So the subacromial space is the space above the rotator cuff tendons underneath the point of the shoulder. It's not actually in the main joint, but a lot of times people who are not shoulder specialists will inject there because that's kind of the easiest space to inject in the shoulder. And it is where a lot of shoulder pain comes from. So often if you go to a non-shoulder specialist and have an injection, the injection will be put into that space. That can be done from the side or from the back. So if somebody tells me they had an injection done from the side, I know that it was into the subacromial space. If it was done from the back, it could be in the main joint or it could be into this subacromial space. With frozen shoulder, the capsule and the main joint is actually what we call the glenohumeral space, the humerus being the arm bone and the glenoid being the socket. And that's where the frozen shoulder is happening. There's often some secondary inflammation in the subacromial space, or what we call bursitis. So you might find you get a bit of relief from a subacromial injection, but unless the injection's into the main glenohumeral joint, it's not treating the capsulitis directly. So a lot of times when people come, they've had an injection that hasn't helped. I'll still like to inject them myself so that I know that the location is exactly where it needs to be. It depends on the exam whether we inject both spaces or whether we only inject the glenohumeral space. And then further treatments, a small minority of patients with frozen shoulder end up having surgery. Usually that is if it's not resolving with those conservative measures, or if it's dragging on a really long time, 6, 7 months. The best candidates for surgery are the ones that are no longer so painful, but may have gotten just stuck in that stiff phase. It's a small minority of people, but they find they can't really get any range of motion back. If we do any sort of surgical intervention on a shoulder that's still painful, it can take a little bit longer to settle down afterwards compared to the shoulder that's no longer so painful, but is stiff and problematic in terms of stiffness. So what we do is a keyhole surgery called an arthroscopic capsular release. So we've got that thick, inflamed, tight capsule, and we release it all the way around, front and back, using a radiofrequency wand, as you can see in the picture. It's done under general anesthesia, but we also like to have the anesthetist do a regional nerve block. So they put long-acting local anesthetic around the nerves that come from the neck, the nerve roots, which cross over in this network called the brachial plexus. And we block that brachial plexus with local anesthetic so that when the patient wakes up after the capsular release, they don't have any feeling from the shoulder and their muscles are also asleep. So the arm is basically floppy, and that allows us to get stretching straight away. Because after surgery to release the capsule, the thing we want to avoid is the capsule scarring back in. And that's what tissue will tend to do when you operate on it or when you cut it. So unlike the non-operative treatment, if we operate, we are really aggressive with physiotherapy straight away. The nerve block will typically last 18 to 24 hours. So we keep the patient in the hospital, not because it's a big surgery, but because we want physiotherapy to start immediately and take advantage of that nerve block and actually get some stretching done passively while the arm is still asleep. The key and the challenging part is to maintain that stretching once the nerve block wears off the next day. And that's why we have people start their physiotherapy straight away after a capsular release. So this is what it looks like on the inside if we have a camera inside the shoulder and the humerus is on the left in the picture that you see on your left. On the right-hand picture, the humerus is on the right. So the camera is looking from the front on that side. This is all the same shoulder. So we've got the camera in the back at the beginning, we're releasing the front, then we switch the camera to the front and release the back. But you can see just how thick that tissue is and how red and angry and inflamed it is. So this is one of the most painful conditions in the shoulder, and people are often frustrated because they've been told there's nothing much on their MRI, or they've been told something completely inappropriate based on an MRI, and nobody's actually put the picture together of the typical history and the exam. There are some other things you may hear about in terms of treating frozen shoulder. Hydrodilatation is something that's sometimes done. The idea is to dilate the joint capsule by injecting fluid, by injecting saline, and then a steroid injection is done at the end. It's probably the steroid injection that actually helps, though, because the capsule is so thick, as you just saw in those surgical pictures, that to actually distend it, to actually stretch it, you would need a really high volume of fluid under quite a bit of pressure. And if that's done awake, as it often is in a radiology department, there's no way you're going to be able to do that to somebody because it would be so painful. The volumes that tend to be put in are pretty small. So I think probably what's helping there is the steroid that's put in. But it's something that sometimes people will try. The other thing you may hear of is an old-fashioned technique called manipulation under anesthesia. And I would strongly advise against that. What that involves is simply putting somebody under general anesthetic and then manipulating the shoulder very forcefully to rip the capsule. And there's a few reasons why this can be problematic. It's what used to be done before we had arthroscopy and keyhole surgery. And it would work in a lot of cases, but there are some potential problems. One is that you're basically tearing the capsule instead of cutting it in a controlled fashion, so it's more likely to scar back in. But the bigger issues are that the amount of force it takes to actually rip that capsule and regain movement in the shoulder can also damage things around the shoulder, including that brachial plexus, that network of nerves going along just under the shoulder joint. I've seen patients with damage to the nerves from manipulation under anesthesia. And I've also seen patients where the humerus actually broke, so they got a fracture from being manipulated. So I would strongly advise against blind manipulation under anesthesia. If you've done a controlled capsular release, sometimes you'll stretch the shoulder gently at the end to make sure there's no last little adhesions, but that doesn't take much force, whereas the amount of force involved in blindly manipulating is quite significant. And I think in this day and age, it's probably not reasonable as it's not very safe. So the take-home message is about frozen shoulder, which we do see more commonly around the time of the menopause, is that the underlying joint itself is normal. And even though it feels really terrible and it's hard to believe at the time when you're going through it, in most cases it will go back to normal in the end without needing any surgery. You need to have a normal X-ray, otherwise you can't call it frozen shoulder. Most of the time you don't actually have to go to the bother of an MRI. And the treatment basically is aimed at decreasing that time to recovery. The natural history is that it should recover anyway, but if we can shorten the amount of time that it's miserable, then I think that makes a big difference to people's quality of life. So pain control, gently restoring range of motion, and in a very small number of cases, maybe an arthroscopic capsular release. Thank you very much.
It's very interesting, and actually you answered a lot of the questions I think that were in my head on it. And I do know people who've had frozen shoulder who literally, you're right, after a year or two it just goes. But so yeah, and after 2 years it just seems to disappear for them. So that is true. Now, someone has asked, at what point should they seek help?
I suppose, if you can stop the process early on, then you may not develop the full-blown frozen shoulder. So I think if you've shoulder pain that's keeping you awake at night, or that's making you struggle with your normal day-to-day activities, that's something that you should go and get evaluated. And so the key is, having someone examine it and decide, what the diagnosis is. And I think that's the tricky part with frozen shoulder. It gets missed or misunderstood a lot of the time.
Okay. Someone, Adele, is asking, regarding heat in the morning and ice in the evening, if this is used as an analgesic, do you suggest the ice on the skin can reduce the inflammation in the capsulitis?
I think it's, there's no hard and fast rules about it. The reason that we say it that way around is typically that the heat will kind of loosen any muscular stiffness and help people do their stretches better. The ice will tend to help with pain relief, particularly at night for sleep. How it does that, you could argue, well, it's probably not going to get as deep as the capsule to reduce the capsular inflammation directly. Is it sort of just providing a different stimulus, kind of like the gate theory of pain control, or is it actually having an anti-inflammatory effect? Hard to know, because the capsule is quite deep. There's muscle and tendon between the skin and the capsule. So the ice may not get all the way into the capsule, but I think it tends to, in a sense, just decrease the pain sensation that people are having from their shoulder.
Okay, thank you. And so, how successful is the operative capsule release in the long term? And at what stage would this invasive procedure be considered versus more non-invasive measures?
Yeah, it's very successful in the long term. Now, you could argue, well, it's frozen shoulder, it's going to get better anyway over time. Yeah. So the people who, and it's very rare, would tend to run into trouble again, tend to be the diabetics. The diabetic frozen shoulder tends to be a bit more difficult to shift. I've only very rarely seen it where they get stiff again after capsular release. I've never seen it in a non-diabetic, so a perimenopausal frozen shoulder. I've never seen not do well after frozen shoulder. You don't jump in with the surgery straight away, and you'd rather not jump in when the shoulder is still in the painful phase. So typically, most patients before considering surgery would be at least 6 or 7 months in. And if they're caught early enough and have started the anti-inflammatory therapy and had injections early enough, they may be better by 6 to 7 months. So certainly, the non-invasive, the less invasive treatments are first line.
Lovely. Ruth, thanks very much for joining us tonight from Italy and taking time out to talk.